everybody. I'm Shauna Donaldson. I'm from the Department of Public Health. I work inside the Maternal and Child Health Division, specifically with the HANDS program. And I got to give a shout out to one of my favorite people in this room, and that is Madison Moore. I was very blessed to work with Maddie at the state office for over a year, maybe almost. I don't know how long it was, Maddie, but Maddie and I worked together, and when she left us to join FRYSC, I was so excited for her because I'm a FRYSC veteran. I was telling Quentin that my very first job was 2 years at a family resource center in Montgomery County, and it was just, it helped shape the trajectory for everything I've done. And y'all are the greatest of the greatest. Let's just start there. And HANDS is right there with you. I got to say that too. Of all the two things I've done in my life, these roles are so important and so vital to families. And so when they asked me to join today, I was really excited to be able to come on and talk about HANDS. And hopefully the goal is that I want to share a little bit about HANDS and some of the early childhood experiences. And so as you all are exposed to families that may be having new babies, and it doesn't have to be their first baby, but as they're having new babies, that you're thinking about us as a referral partner for you, because anybody can refer to HANDS. And I was telling Quentin when I worked at the HANDS program in Clark County, I had a great relationship with the youth service center staff. They were fantastic for giving us referrals, as well as the family resource center for the families they were seeing as kids were coming into elementary school, were having new siblings, or in the preschool setting. And so it's just a great natural partnership that we don't think about sometimes. And then the other plug I want to give is that I'm also hoping to be with you all at the Victory Over Violence. Am I saying that right, Quentin? Have I phrased that conference right? I'm going to try to come and present there, where I'm going to be expanding upon the conversation that I'm talking about today. Today, I'll spend a little bit more time talking about HANDS. And at the Victory Over Violence conference, I'm going to be talking about, let me look at my notes. The name of the session that I think is going to be Before They Walk Through Your Doors, How Early Experiences Matter. And I'll be expanding the conversation around social determinants of health, adverse childhood experiences, and how all of these early childhood experiences impact school readiness, and how these sweet little ones show up in our classrooms. And I remember when I worked in a FRYSC in my own family resource center, I didn't have an appreciation then for how important those first 3 years of life have for what I was seeing in the schools, and for what families benefited from in terms of support. So I'll be really excited to be with you all to talk about that. So if you see me there and you want to come, I'd love to be with you. And I promise it won't be a complete repeat. I'll try not to bore you to death. So here's where the magic happens. I'm going to try to share my screen. So I'm going to ask for a lot of grace with this, and we'll see what happens. Okay, here we go. Let's see. Okay. So you can let me know if that pops up, or you can see the presentation. Everybody good there? Perfect. Okay, now I think I can get us started. And I've asked Quentin, you all, I want you to feel this is very informal. So if you want to ask questions as we go through, I may not be able to see you because I'm going to have a really limited window that I can see you in. But I've told, I'm happy to take questions as we go through, or questions at the end if you have them. So very casual. The other apology, let me go ahead and offer, is that my computer did an update last night and my camera keeps turning itself off. And so don't take it personal if I just disappear my camera. I'm here with you, hopefully. It's just decided I shouldn't be on video. And it's probably right. So, okay, let's talk about it. So we're going to talk about how HANDS supports Kentucky families. And as we walk through today, I'm going to talk a little bit about adverse childhood experiences and social determinants of health. And then I'll explain a little bit more in depth about HANDS, because HANDS is one of those programs a lot of people have heard about and they're not quite sure how it works. And so I'll try to give you a little bit more history on that. Before I do, I'd like to share one of my favorite stories with you, because you all are at the same place with me at the mouth of the river. And so I want to share a story about what I'm talking about, the mouth of the river. And probably many of you have heard of the upstream analogy or the river parable. And there's many versions of it. And if anybody wants a version of it, let me know, and I can pop you a couple of links to it. But the version I share was told to me by Dr. Otto Cake. And Dr. Cake was with the UK Department of Child Psychiatry. He served as both a child and adolescent psychiatrist at UK, and he had joint appointments from the Department of Pediatrics and the College of Social Work. And the way I really experienced him was through his work with the UK Center of Trauma in Children. You all may have heard referred to it as CATS, is one of the acronyms we used to talk about it. And Dr. Kate came to the field of childhood psychiatry from family medicine. And what he shared with us is that when he graduated from medical school and as he worked in family medicine, he quickly realized that many of the health concerns coming from patients were related to their emotional and social well-being. And that realization sent him back to medical school to train in child and adult psychiatry. Because what he come to understand as a family practitioner is that if he was going to help his patients, he had to start with those root causes of medical conditions by addressing their life experiences. And his remarkable career just exploded from there. He touched families and practitioners in the most indelible of ways. And so I'm going to try to share his version because it's so much better than what I would tell. So the story goes that there are some people standing on the banks of the river. They're enjoying picnics, they're playing games, and they're fishing. And suddenly a baby appears in the river in front of them, and this baby is struggling. One of the people jumps into the river and pulls the baby out, saving that little one. However, a few minutes later, an older child comes floating down the river, also struggling, even a bit more so than the baby. So it takes a couple of people to jump in and pull this child out. And it takes both of them and extra efforts to save the child. Then the group looks up and they see some adults floating down the river in dire need of help. So nearly all the people jump in the river and they start pulling the adults out. And for the adults they're pulling out of the river, it takes more of them and more of their resources that they're actually close to running out of, and a lot of energy to help take care of the adults. And meanwhile, as you can imagine, there are more babies and children still in the river, more adults, all floating downstream towards them. The group is becoming exhausted and fearful of what is happening and not knowing how they're going to be able to continue to save all of the people coming down the river, when suddenly one of the individuals takes off running upstream of the river. And a member of the group shouts and asks, "Where are you going?" And she yells back, "I'm going to go upstream. I'm going to the mouth of the river to see why these people are falling in or getting thrown into the river." And what we hope is that as you think about that story, we can connect the dots, that we have to understand why people are struggling, what those root causes are, and to be able to impact those, we have to understand it or we can't make change. The story also hopefully illustrates that the more quickly we can provide aid and help, the earlier in life, such as each of you in FRYSC settings, the earlier we can provide the support that families need with those preventative efforts or early intervention, the less is required in terms of resources and professionals to support people. Then overall, our efforts are much more successful. There's a much bigger difference in myself or one of you all providing support to a family that maybe they're struggling with mental health or intimate partner violence or neglect. It's much easier for us to get involved and provide those resources and supports versus what happens when that person continues in that situation. And then at 30 or 40, it's a much different need that person has to have what they need to live a full life. And so all of us are in a really unique spot that we are all at the mouth of the river. The work that you do and the work that we do in hands, it places us at the mouth of the river. We are seeing families before the problems and concerns become so significant that the interventions are much more demanding and the resources are less available. So that's where we are, and that's where I want to ask you to join me. And so I'm going to spend just a little bit of time talking about some of the things that happen in early childhood or in our lives that impact where we are and the supports that we need. And I'm sure all of us have heard of the CDC Kaiser study regarding adverse childhood experiences. And if you'll just bear with me, even though you've heard of it, I'd like to walk through it because I think every time you hear it, you pick up something different from it, or at least I do, or I have a different context to kind of layer it onto. So the original ACE study was conducted at Kaiser Permanente in California from 1995 to 1997. Excuse me, with 2 waves of data collection. Huge study, over 17,000 HMO insurance members from Southern California participated. So think that'd be like 17,000 of us that participate in the state health insurance plan, right? It's that type of an HMO that all of these people have. I would consider them everyday people like all of us working with regular health insurance. And as part of this study, the 17,000 individuals, as they were receiving their physical exam, they also completed confidential surveys about their childhood experiences and their current health status and behaviors. And these surveys were designed to collect information on their experiences as a child, and the age of a child during the study was considered up until the age of 18. What were their experiences with abuse, neglect, or household challenges? And abuse could be defined as emotional, physical, or sexual. Neglect could be defined as emotional and physical. Household challenges were considered like intimate partner violence, substance use in the home, mental illness in the home, maybe parental separation or divorce, or an incarcerated household member. And so as I'm saying that, you are probably doing what most people do is you're going through my list and you're going, oh, have I had that experience? And the findings were remarkable. Over 2/3 of the study participants reported at least one ACE score. And I don't know how many of us are in this room, but if there are 10 of us, I could say that 6 of us have at least one ACE experience. That's how common they are. I am one of those 10 people that I have one of the ACE experiences. That also tells you that if you look at your schools and the children you serve, 6 of every 10 children have an adverse childhood experience, and they're currently living in it probably. Or they have, or they will. That's just how common these are. 61% of us. It's unbelievable. And there's a lot of information about ACEs that you certainly can research, and I'll be happy to share more. But where this study goes is really what they found out, right? It's one thing to know that we have these high numbers of ACE experiences, but what does that really mean for us? Which all of us in this room certainly understand the immediate impact of an adverse childhood experience. We see those when they happen in school. A child experience abuse or loss of a parent. When you've seen that in the children that you all serve, you see how that shows up and what those repercussions look like. It could be impacts on their mental health, homelessness, depression, anxiety. So we can see those things pretty quickly, those immediate tolls. But what was so interesting about the research was that in addition to what we know as these immediate impacts when one of these experiences happens, they kept finding increasing evidence that exposure to traumatic experiences also influence our long-term physical and mental health, which contributes to this public health burden for the U.S. population. Studies have indicated that trauma that results from an adverse childhood experiences can prompt coping responses that may have like health risks, like tobacco use, heavy drinking, unprotected sex. So we understand that, right? Again, we go, okay, we've had this trauma, I need to cope. So I'm going to pick up one of these behaviors that helps my coping. Not that we do it consciously, but that's what happens in many times. So when the study was first published, many people assume that they go, oh, okay. If you've had a difficult childhood, you're more likely to drink and smoke to help you cope, which are also things that can help ruin your health. So it makes a lot of sense. So that it wasn't like really anything new there, because we already know that these health damaging behaviors are bad for our health. But here's the big deal. It turns out, let me back up. It turns out that the whole story on how ACEs impact long-term health is much deeper. They ended up doing a logistic regression analysis where they went back and looked at over the long term and over the near term, what were the real impacts of if people had adverse childhood experiences, what did it really mean for their health damaging behavior? And what was fascinating is that um, behaviors only accounted for about half the risk. So if you look at this slide that I've got up right now, if you have adverse childhood experiences, these are some of the common health problems that we see resulting from those: heart disease, depression, risk of injury, cancer. And so when you look at that, you go, okay, I get that. But now I'm telling you that behaviors only account for half the risk. So we can go that, yeah, if somebody smokes, we are more likely maybe to see lung cancer. But what makes if you don't have health damaging behaviors, then where does the rest of the risk come from? Why are you more likely to have these negative health outcomes? And what they discovered is that evidence has linked exposure to ACEs, adverse childhood experiences, exposure to these incidents increases your toxic stress. And so toxic stress produces what we call systemic inflammation throughout your body. Okay, it means that your overall health is impacted because of this inflammation. So let me walk through this a little bit. The fundamental mechanism of stress means that your body goes into flight, or freeze response. Now, I think they've added one more letter to that response now, but you all know, like if you get scared, what do? Some of us freeze, some of us come out punching, some of us take off. And that's a very typical response when you have a sudden experience. And that's what our bodies are supposed to do. When we experience something scary or traumatic, it releases all these stress hormones in our body, like adrenaline and cortisol. And those things are important because they raise our blood pressure, they raise our heart rate, and they raise our blood sugar. And all of these things are really important if you're facing a mortal threat. So, for example, if you're in a forest and there's a bear coming up on you, you want your body to do these things, because your body is getting activated to be able to respond to this bear attack if it were to happen. That stress even changes how your brain functions. Your brain starts to shut down. The thinking part of our brain shuts down and our cortex gets activated, which helps us respond very quickly. We go into our prefrontal cortex, and it's exactly what we're supposed to do because it helps our immune system activate. And if that bear attacks you, all of these things that your body has done to raise this inflammation in your body is going to help stabilize your wound. Now, here's the question I want you to ask yourself. What happens, though, when that bear comes home every night? Some of the children we serve, their bears come home every night. Or when they get off the school bus, the bear lives in their house. Some of us have lived with bears. And what that means is that our stress, or these children who we serve, their stress responses get activated over and over and over again. So all of a sudden, the stress response that's so important for us to help save our lives now becomes maladaptive and health damaging. And children are very sensitive to these high doses of adversity because their brains and bodies are just developing. So what happens with our kiddos is that they have changes in their DNA and in their brain. If you've ever heard the word epigenetics, it basically means that trauma will follow you through your genes. It's absolutely true that if my parent grew up with a lot of adverse childhood experiences, her genes got passed on to me. So I already have a predisposition, so to speak, because it changes, right? Our children are developing. And so as they develop, all of these things change. So now I'm going to go back to these health issues. With this chronic elevation of cortisol and inflammation, it changes our cardiovascular system and our body's ability to repair itself. And that's why you see more incidents of cancer, diabetes, heart disease, and depression. So that chronic inflammation that comes from adverse childhood experiences, it damages and it creates wear and tear in our bodies. And so we have greater health risk. And so one of the examples that they found is that if you know someone that had 4 or more adverse childhood experiences, they are at 2.5 times the rate of having risk of having a stroke as a person who does not. So that is the power of adverse childhood experiences. The other thing that I want to touch on that all of our kiddos face and our families face are what they call social determinants of health. And Quentin, I'm going to ask you to help me watch my time. I think, is it 12:54? Okay. Just wanted to make sure I'm doing good on time. Okay. Social determinants of health, or social drivers of health, is what I like to call it, because I don't like the word determinants. It feels too final and that you don't have any control over it. But according to the CDC and the Healthy People 2030, they have identified that there are social determinants of health, things that are non-medical that influence our outcomes as individuals. And these are the conditions in which people are born, grow, work, live, and age. And these forces and these systems are outside of our influence. And so if you look, we have things like education access and quality, healthcare access and quality, neighborhood and built environment, social and community context, and economic stability. So what this is telling us is that these things that we see on this chart are really beyond our individual control. And I know you all see this every day. I have worked in communities where there is no public transportation, right? And so I've served people that if they live in the county 5 miles out and they don't have a vehicle, they can't get into town to get groceries. They can't come to parent-teacher meetings at school, right? I see that impact. That is beyond their control. Maternity care deserts or healthcare deserts in Kentucky is really frightening to me right now. The number of hospitals that we have closing, because I work in maternal and child health, I see families that are 2 hours from a hospital. So when they're ready to deliver their baby, they've got to go 2 hours away. Which then if they don't have a provider in their community, they're going that far away to get their health care. Again, this is something beyond our control. These are the environments that have been built. Economic stability. Some of you all may work in communities where employment is not rich. Right now, we know that employment is really difficult anywhere you live across the nation. But many communities, if there are not factories or places that hire frequently, or they have small hiring pools, our families cannot find work. And so these are the things that impact the children we serve. And they have linked ACEs, those adverse childhood experiences, and social determinants of health. And I think you can think of a really practical example. If you have a family that lives in poverty because maybe they don't have access to transportation, and one of the parents is not able to work, that creates more stress in their marriage. And then if they separate, all of a sudden that child has an adverse childhood experience simply by that parent's separation and divorce. So they are very connected with each other. and one impacts the other. And so, again, it's something that our families cannot control, but it is something that impacts them. So, if we connect the two together, how I like to think about it is ACEs are often the things that we can see at the top of the tree, right? It can be maternal depression or abuse or substance abuse or mental illness or homelessness, whatever that might be. And the environments they live in are the roots. The roots create the conditions for the things that we see sprouting on top. Is that when you have poverty and violence and poor housing and lack of opportunity, all of those things impact or increase the likelihood of adverse childhood experiences. And again, this is another one of those slides that you can pull up, and it's out there and it's access for anybody. And again, I'm happy to share these afterwards if somebody feels like it'd be helpful to you to have access to some of these slides. So what we know is that we have to go upstream. Where you all are, where I am, is where we have to work if we're going to make a difference for families. And the ways that you all do this and the ways that we do this in HAND is that in HANDS, we screen specifically for risk factors. And so we are screening for intimate partner violence and mental health needs and home safety. You may not be completing screens per se yourself, but you are screening all the time the families you work with, right? You are doing this informal kind of, where can I help them? What supports might be helpful? Or this is a concern I've identified. We have to build protective factors for families. You are a protective factor already. Just your existence in the schools is that you are creating a protective factor. You are what I love to refer to as a positive childhood experience, a PACE. We have adverse childhood experiences and positive childhood experiences. And each of you all are pacers in my mind. You are those people in the schools that help children have stable relationships. You create safety for those children, and you're helping their families think about the environments and the experiences they're in to create a nurturing place. And so you become a PACE. And so that's a way that you and I are upstream, HANDS is upstream. Another thing that we all do is we're always seeking to improve the disparities that our families feel, whether that's supporting maybe early childhood education, whether that's health, community, and access to services like employment, maybe it's public health prevention, but all of these referrals that you make is connecting them to opportunities to minimize those disparities. And the last one on there is providing those safe, stable, nurturing relationships. You all do that. Children need that. You give that to them. And anytime you can set them up with their caregiver to have a safe, stable, nurturing relationship, that is a big piece of it. And that is at the heart of what we do at HANDS. Our primary, I like to think about HANDS as having maybe 2 to 3 goals, or not goals, but 2 to 3 aspects of our services. One is we are like a case management service, kind of in the same spirit that you all are in, where you're always thinking about what families need and what supports can you offer. We do that with HANDS. We're just doing it in that prenatal to 3-year-old population. We're getting them before they come to you in the schools. So that's where we're located at. And then the other thing that we do, besides helping parents understand about child development, is we are always promoting nurturing relationships. I did not know this when I worked at a family resource center, but a child's attachment to their parent and caregiver is one of the number one predictors of a child's success. A child that feels loved and cared for is more ready for school than a child who is not. And you see that, you may not, you know that anecdotally, you can tell that story, but the research proves that that is true as well. And so that's what we're doing in HANDS, is we're trying to catch these little ones before they show up in the school doors to help give them all the foundation we can to make them more ready for school and all those opportunities coming their way. And you probably can't see it very well on the PowerPoint, but my population is maternal and child health, and so it is prenatal and early childhood. And the outcomes in Kentucky are not good. We are not a stellar state in terms of the outcomes for children. We have some of the highest mortality for both mothers and infants in the state. In the nation, we are not ranked well. And maternal deaths, over half of our maternal deaths in Kentucky is connected to substance use as a risk factor. So we've got a lot of opportunities to support the families we serve. So this is the part where I'm going to spend maybe the next 15 minutes just talking about hands and digging into hands a little bit. And then I will certainly answer any kind of questions that you have, and we'll go that route as well. So hands, we are an upstream support like you are. We are a voluntary home visiting program, and I'm going to talk about the word home visiting because you, my friends, know the fear of home visiting. I know when I was a family resource center staff person, I did home visits, and families weren't so crazy about me coming to see them until they figured out I was their friend and their pal, and I was there to support them. And so we had that same experience in hands that you all have too. The first time a family hears you want to visit with them in their house. We are a voluntary program. Nobody can court order us. Some judges will put us on a family's reunification plan, and they can put it on there, but we cannot be court ordered. We want to work with all families. And we want it to be voluntary. We are in all 120 counties in Kentucky. Most of our hands programs come directly out of the local health department. And so if you need to talk to a hands person, that's who you call. You call the health department and say, can I talk to the hands program? And that will get you right there. The only 3 areas where we're not in the local county health department would be the Louisville, Jefferson County area. Fayette County, we're in their health department as well as another program, and then in Northern Kentucky. But if you still call that health department in those 3 areas, they will still connect you with the right people. So you don't have to go on a search to find that out. We are designed to improve both health and social outcomes. We're really proud of the fact that our hands program is a nationally recognized evidence-based model of home visiting. What that means is the research shows that what we do produces the outcomes. And so you can feel good about your tax dollars, my tax dollars, all going to support the hands program and the services that are happening because we have evidence to support that. Hands is a core foundational service. And what that basically means is it has to be offered. It's one of those things that is not optional for the health department either to provide or to help us find a provider. It is that highly valued. And all of our services are provided by qualified staff who have had a lot of specialized training. And I'll touch on that for you to give you some confidence that you know who you're talking to. Hands history, I'll just highlight that we have been around since 1999 was our first pilot. And in 2002, we expanded from that pilot. And by 2003, we went statewide. And then in 2010, we expanded again. Our program was only for first-time parents. Now it can be your second birth. And oftentimes, even if it is your second birth, if there are different parenting partners, it might still qualify as a first-time birth. And so we serve a lot of families after they have their first child. So they may be on child number 3, but if they've never had hands, that would still be their first enrollment. And maybe I should say it that way. They get 2 enrollments with hands, whether it's their first baby or 5th baby. We just limit it to 2 enrollments overall. Hands is also, this is coming up. Let me share this. Hands is also a service that is provided at no cost to the family. We are covered by Medicaid because of our case management aspect of what we do. We refer services. Then we also receive tobacco dollars back in 99 when there was tobacco settlement lawsuits. All early childhood programs in Kentucky were recognized as a beneficiary, and so we still leverage some dollars from that. And then we also have our federal dollars, which is this federal grant that I'm talking about. So you don't have to worry about, does a family have Medicaid? Do they have health? It does not matter. We will serve anybody, and there's no cost directly to that family. We will recover that cost in another way. Our vision of in hands is that every child is wanted and cared for in a nurturing environment. And then the goals are what are really important to me, is that we want to support families to have positive pregnancy outcomes, their children to grow up healthy, to grow up in safe and healthy homes, and family self-sufficiency. And I think all of us on this call have those things in common. We want those things for all families. So what does hands look like? And so if you were to refer a family to hands, this is what that path would look like. The very first thing is we get the referral. What's important for you all to know is that we have to have that referral before that child turns 90 days of age. Now, we hope to change that and open that eligibility up, but right now it is 90 days of age. And so we want to get them prenatal if we can, because we know our outcomes are stronger prenatal, or we have longer, maybe a better onboard to support that positive pregnancy outcome. But by 90 days of age, we have to have that referral. Then within that, we try to make it within that first 5 days of getting that referral, if at all possible. We do what we call a family engagement and resource visit. Now, we don't have to do it within 5 days, but we want to offer it within 5 days because we want to respond quickly to your referral. And what that visit looks like is that we have there's a staff person in each county that will meet with that family. They'll understand and listen to what concerns do they have, what are the strengths of that family, what kind of supports does the family have. And through this dialogue, this conversation, we figure out where can we offer them referrals. And that's the very first thing we do is in that initial visit is we will connect them with every service we can think of that will support them. And then if a family, I'm going to use the word qualifies. I don't like that word, but if a family qualifies for hands, we will then offer them ongoing services. And people sometimes they believe that hands is only for families that maybe have Medicaid or families that maybe are at a certain age or whatever. What I want to dispel for you is hands. I consider it for everybody. I did direct service for hands for about 15 years in Clark County. And I had 3 families in 15 years that did not qualify for hands. And I found out after the fact that 2 of those did qualify. I just didn't get that information in that first visit. I qualify for hands. And I share that with you to say that it's really hard not to qualify for hands. It's if you have any number of things, so like for myself, I would have qualified for hands because I adopted my son. I had a parent who was an alcoholic when I was growing up. And there was one other factor. I can't remember what it was, but it was really easy, right? It's very easy to qualify for hands. And so I don't want you to think that it has to be this family or that family. Give us the referral and let us talk with them. Because even if they don't qualify for ongoing services, they all get this assessment visit, which is full of resources and information for them that can help them through their pregnancy. If a family does qualify, we can then provide them services until the age of 2 or 3. And I'll share with y'all one of the big secrets that we're getting ready to share statewide is that we are expanding to the age of 3 across the state very soon. And so that'll be statewide. We've been piloting that and we're ready to move forward with complete expansion. And through those home visits, there's 2 different things that happen. One is they get what we call a quarterly visit, where someone comes out once a quarter and just kind of does an overall conversation with the family to see if things are going well, if there's things they need, kind of that big picture view. Then they also have an assigned home visitor that will see them weekly, usually for a period of time. And then they will decrease those visits as families move through the program. And those weekly visits, I'll talk about a little bit more just in a second. And then every staff person who provides services to family also gets weekly supervision time with their supervisor to talk about what are their concerns, what are they seeing, and how can we support our staff. I talked a little bit about this family engagement visit. That's the assessment visit. And what I would just point out is that we're really just trying to hear the family story. That's what that whole first visit is about. We just want to hear about their experiences, their health, their family life, their basic needs, those kind of things. It families, a lot of families really appreciate that first visit because they like being able to tell their story. So many people never ask us what our stories are. And so families really respond to that. Ongoing home visits. I've got listed here several of the things we do. We develop trusting relationships, just like you all see the same families every day. We have our home visitors who are assigned to a family. So we try to keep that consistent so they get to know that person, that face, that relationship. We complete those screenings that I mentioned, whether that's for child development. We screen for child development and make referrals to keys or first steps, early intervention services if needed. We screen for depression, intimate partner violence, and safety, and we'll make all of those referrals if needed. We provide access, or not access, referrals to any community partner. Maybe it's the school, WIC, food stamps, whatever that might be. We refer to all those services. And we try to provide most of the services in the home because, as you all know, once you get in the home, you know what it really looks like for a family. It's far different seeing a person in a clinic versus seeing them in their home setting. I worked in home health for years, and they would send patients home and go, oh, well, they were stable when they left the hospital. And then I'll say, well, at home, they've got steps they can't walk up and down. So they're not, they can't manage there. So it's a whole different place, seeing people in their homes. And so we try to do the majority of our visits in the house. We use a set curriculum. So our home visitors go out. They're not making up things as they go. Their curriculum is a nationally recognized curriculum, and it covers the prenatal, birth to 36 months. There's a special manual that's all about building family resiliency. We have a Hope at Home curriculum that supports families with substance use disorder or experiencing substance use disorder. And then we have another curriculum that we can use for our groups. And every home visit requires the use of the curriculum to make sure that we're giving families accurate information. This slide just again points to some of the things that's happening in the home visits. And what I really want to point out is that if you look at this, you see that one of the primary things we're doing in the house or when we're with families is we're trying to figure out how to support that nurturing and attachment relationship. And so we're watching those cues. We're watching their communication. We're trying to see how parents respond. And if we see opportunities to strengthen that, we certainly want to provide that support. Some of you all, how many of you all have heard of the Harlow's study with the monkeys? If you have, I'd recommend it, but I don't like it because it upsets me every time I see it. And so if you've got good emotional fortitude, you can go out on YouTube and find it. But in the Harlow scientific study, they took baby monkeys, and they had two different sides of a cage, and on one side of the cage was a soft plush monkey, and the other side of the cage was a metal frame of a monkey that held the food, that held nourishment for the baby monkey. And what they found was the baby monkeys would go to the soft plush monkeys to feel warmth and cuddling and would starve. They would not go to the wire frame. And we know the same thing is true in early childhood. We all need to feel safe, cared, and loved. And Harlow's monkey is a horrible but yet beautiful example of what attachment really looks like and what people need for attachment. And so that's why everything we do in hands is through that focus or through that lens of helping parents and children fall in love with each other and to be attached. Just another kind of interesting thing is that we really promote early literacy and reading and communication with families, because we know children from low-income families hear approximately 600 words every hour, which is 1,400 fewer than children in higher income families. Think about that, 600 to 1,400, which eventually becomes what they call the 30 million word gap. which is the difference in vocabulary from 18 months old and 24-month-old, is that the amount of words helps determine their vocabulary. So we're in there working on those kind of things as well. So you want us to be your partner to help our little ones get a fresh start for school. I'm going to start to wrap up a little bit. I want to assure you that all of our staff are very trained, that you can trust that we put our staff through the paces. They have caseload standards, that they have a maximum on the families they can see. They get that weekly supervision, and they go through rigorous training, including adult infant CPR, pediatric abusive head trauma, recognizing child abuse and neglect, intimate partner violence. And then beyond that, they have to do an additional 100 hours in the first year of training. And then they're doing curriculum training at the same time. So we're really well trained as far as what we're providing when we go out. How we at the state office, where I'm located at, the kind of support that we provide to the local programs is that we give them the model that they're expected to follow. So everybody that does HANDS program is delivering it in the same way. So you should not find differences in county to county as far as eligibility and what they're doing. We support their training. And then we have our QA and TA specialists, our quality assurance and assistance specialists, who go out to support the local programs, make sure that quality and fidelity is there. This slide just lists all the different ways that we impact ACEs and social determinants of health. And if you were to layer your all selves onto that, I think that you would find that you're doing almost all of these things as well. We're just working in two different populations. I've got the prenatal and early childhood, and you have the school age that children and families that you're working with. And I share this statistic. I think it's just really insightful. Is that, and this is from 2023, that 50% of our referrals came directly from health departments, which makes a lot of sense because we're located in health departments. 17% of our referrals came from families referring themselves, which we're really proud of. What frightens me is that if you look at hospital and OBGYN providers, they're only about 11%, 12% of the referrals. We'd like to see them be our top referral source. And so you all would fit in that other category, which again is it's a good number. We'd like to see that number go up as well. And you can also help us by helping your local providers be aware of HANDS, just in addition to what you all are doing. And so how do we work together? Here's the ask that I would have of you. It's if you're talking to families about HANDS, is remember that HANDS is for everyone. Please be very careful about not using any kind of deficit-based language, like at risk. For me, that's a deficit-based word. I don't want to think about myself being at risk, but if you want to say that I qualify for HANDS, that makes me at risk, okay. But it's not a way that a person wants to be thought about. So try to avoid that kind of language. Remember that we can get everybody that initial visit as long as we get that referral before the baby is 90 days of age. Even if they don't do any other services, we can do that initial visit and make all of those referrals for them. You just have to call your local health department. We are creating an online referral form. We hope to launch it this year where you wouldn't even have to call the health department. There'll just be a website you'll go to. You'll put in about 4 lines, like name, address, phone number, and that'll be it. And then we'll pick it up from there, and it'll even be sent to the right county. The other thing, and I did not have this on here, so let me touch on this. The other thing that I want to mention, and I'm going to stop sharing as I say this, is that if you're talking to families about HANDS, maybe avoid describing us as a home visiting program for the very reason that you know. If you tell them that you want to refer them and a home visitor is going to come out and see them, who do they think is coming? Child Protection, CPS. And so we really try and are asking all of our partners to avoid describing us as a home visiting program. What you can just say is HANDS is a service in all communities. They will serve first-time or second-time parents. It doesn't matter. They'll serve anybody that's pregnant until the baby is 3 months of age. And we just like for you to talk with them to see what services they may know that could be helpful to you. And that's all you have to share. because we will sell the home visiting part. It is just like you all know how to get yourselves in the house. I'm preaching to the choir today, I think. Just like you know how to get families to connect with you and invite you in and be part of their lives, we're pretty good at that too at Hands. And so just leave that part to us and we will sell ourselves to get into the homes. So that's what I have for you. If you have any questions, I'm happy to take them. And again, at the Victory Over Violence, I'll just be expanding on a lot of those things I talked about at the beginning of this. So Quentin, I'll give it back to you, and I'm also ready for questions if anybody has any.
All right. Well, if anybody has any questions, we'll give you a minute here if you'd like to come off mute or put something in the chat. Yeah, Molly, go right ahead.
Thank you, Shauna. I do live or I work in Northern Kentucky, so I think we are one of the locations that is provided through Brighton Center instead of
Yes.
the health department.
Yes.
Do you know how easily available Spanish speaking Hands employees are?
Yeah. So there's two different ways I can answer. There's like three different ways I can answer that. We are required to provide translation services, whether that is an employee, us using an interpreter, or an interpreter line. And so many, Spanish is probably our most common second language. It is our most common. It is our second language that's the most prominent. And so many programs, probably especially in Northern Kentucky, more of the urban areas, they really try to staff with bilingual speakers. And so I would imagine you would find quite a bit of that in Northern Kentucky. Where I was in Clark County, we had an interpreter service that we used 2 days a week where a staff person would actually come. In some communities, it can be harder, like I'll use like Jefferson County. They have a huge multilingual population, and so they can't always hire staff. So they'll try to use interpreters from organization or the line. But it should not be a problem. Sometimes there might be a little bit of a delay if they don't have a staff person, but they'll figure it out.
Thanks.
You're welcome. And the curriculum is in Spanish too, Molly, which is really nice. We don't have it interpreted or translated in all languages because that's our national provider that does that. But Spanish is the curriculum that parents get their materials in Spanish. So, great question. Thank you.
Hi, Shauna. This is Heather
All right.
McCarty.
Any other questions?
Oh, sorry, Quentin.
Go ahead.
I just want to say
You
thank
go
you so
right ahead.
much.
No, you go right ahead.
I just want to say thank you so much for this presentation. I've learned so much. I'm really
Good.
looking forward to hearing your presentation at Victory Over Violence and at our regional meeting later this year for Region 2. And I just think FRYSC coordinators have the great opportunity to make referrals and they have that expertise in families and protective factors. So the more they can learn about hands, the more, referrals they can make. So
For
great
sure.
presentation. Thank you so much.
Oh, good. Good, good, good. I'm glad you enjoyed it. And hopefully, like I said again, in July, I really want it to be an expansion. So if you come, you may hear some things repeated. But again, we can hear it in different contexts, but I hope to expand upon some of those ideas as well. So a little bit deeper for you. Yeah.
Yeah, thanks, Heather, for saying that because that's something I was going to reiterate myself. We appreciate the information, and I think this could be a great partnership for people to work together. And I learned, I worked in the health department 2 years myself when I first out of college, and there's some things I'd forgotten and things have changed. So great information for me as well. So we appreciate Shauna taking the time to share this information with us, and we'll get this recording put up for us. And I'll give you just another, if anybody else has any other questions, feel free. I'll give you another minute, then we'll stop the recording, then I'll share some the end of session information.